The talk today is about this paper that was published recently. The title is Controlled Backfill in Oncology Dose-Finding Trials. So hopefully by the end of the talk, you will know about dose-finding trials, you will know about backfill and what we mean by controlled backfill in this case. So that's the structure of my talk. I'll start with a brief introduction to dose-finding trials. Then I'll talk about the problem at hand. Toxicity with new oncology agents may not be a surrogate for efficacy. And then I'll talk about how backfill patients may help in this context. So, dose-finding trials, quick introduction, but I think it's important in the sense that if you're not familiar with dose-finding trials, it will be really difficult to follow the rest of the talk. So, dose-finding trials, what are those? They follow preclinical research. So it would be after research in cell lines, so in vitro, in vivo, as well as after animal models. These are very small trials, 20 to 100 participants in general. And it's a very important step in the development process of a new drug or a new compound. If a drug doesn't perform as expected at phase 2 or phase 3, it might well be that it's because the dose that was chosen is not appropriate. And that would be a missed opportunity to make a difference. So we are talking about phase 1 studies in this talk. Now, dose-finding trials, they include different dose levels, often up to 7 or 8 dose levels. And what you try to do effectively is identify the most appropriate dose to recommend for further study. Phase 2 trials in particular, and how to do that? Well, we have to take into account multiple factors, including toxicity, including efficacy, quality of life, cost of the drug, etc. There are 3 broad classes of approaches that we can distinguish. Parallel arm trials, where patients will be randomized simply between the dose levels. That doesn't happen in oncology, which is the topic of the talk today. Within patient dose titration, and then dose escalation studies. And today we're talking about dose escalation. Participants in phase 1 trials, who are they? Well, it depends on the disease area. It can be healthy volunteers or patients, often older than 18, adequate heart function, good immune response outside of oncology. And in cancer, and that's an important point for the rest of the presentation, they have exhausted all available treatments. In some ways, they are at the end of the road, but they still have a life expectancy greater than 3 months. They are monitored often very closely in clinical trial facility for phase 1 studies because it's first in human. Now, I'll talk about this a lot during this presentation. The fundamental assumption in dose escalation studies, there is monotonicity of the dose toxicity curve as well as the dose efficacy curve. It is not unreasonable, especially for cytotoxic drugs, which means chemotherapy drugs that kill the cancer cells, to assume that with greater dose levels, you're going to encounter greater toxicity. The dose efficacy is also assumed to be monotonic. If there is toxicity, it means that the drug is doing something. It's killing the cells, and therefore you expect that the patient will recover, right? What do we do in practice? Or at least that was the paradigm in the past with chemotherapy. We were trying to identify the dose level that was closest to, say, 25 or 30%. That was the highest possible percentage that was seen as acceptable in exchange for efficacy in the other patients. If 1 patient out of 4, 1 patient out of 3 is experiencing side effects, the remaining patients are benefiting from the drug without too much side effects. And this is the trade-off that was the main paradigm with chemotherapy. So how do we do this in practice then? How do we actually identify the drug? These dose escalation trials, they tend to be adaptive and iterative. What do we mean by adaptive trials? The dose that is given to a patient or to a group of patients depends on the result of previous patients. What dose was given to the previous patients as well as their outcome. And it's iterative. So effectively, we repeat this process until the available sample size is recruited, or we have a termination rule for the study. Two broad classes here in terms of dose escalation approaches. One is called rule-based design, the other one is called model-based design. 3+3, it's an example of rule-based design. Before I introduce the 3+3, I'll just speak a bit about the terminology in the field. So DLTs are dose-limiting toxicity. So these are adverse events of sufficient importance that you would not further escalate inside a patient. An example would be what we call grade 4 neutropenia on a scale from 1 to 5, which would last for more than 7 days. And what does it mean? It means that there is a lower than normal number of neutrophils, which are a type of white blood cells involved in the immune system. And the MTD is maximum tolerated dose. And that is the dose that in the chemotherapy paradigm was expected to be identified. So what do? This is the rule-based design, so it's effectively a simple algorithm. We start at the lowest dose level, we dose the first 3 patients, and we count. We count how many patients out of 3, it's very simple, have experienced at least 1 DLT. And depending on the results, we make decisions for the rest of the study. If there are no DLTs, then we can escalate to the next dose level. If there is 2 or more DLTs out of 3 patients, we would stop the study. And if we are at the first dose level, this means that there are no MTDs. Otherwise, if we have escalated, then it would be the dose level below that would be declared the MTD. If there is 1 DLT, then we add 3 patients at the same dose level. So this is the 3+3 algorithm. Very simple to follow. Depending on what happens after the other 3 patients, if there are more than 1 DLT, then if it isn't the case, we can escalate. But if it is the case, the study is stopped. 3+3, it's just an example of a rule-based design, and there are many other rule-based designs that we can use in dose escalation studies. Then, as I said, there are rule-based designs, and then the other main class is model-based designs. The continual reassessment method is one of the model-based designs that can be used. So we are not just counting the number of DLTs here. We are working with the estimated probability of DLT for each dose level. So it's a model here. On the right-hand side, you've got the evolution of a hypothetical study. So the first 3 patients at dose level 1 did not experience any DLT. That's why the dots are white on this plot. Then the second group of 3 patients, who were those at dose level 3, top right, have seen 1 DLT out of 3. The study then escalates and stays then at dose level 4, dose level 5, sorry, in this case, and continues until the end, with a couple of patients, 4 in this case, experiencing DLTs. At the end of the study, at the bottom, we've got the model, the resulting CRM model that describes the probability of DLT at each dose level. And the red horizontal line is the target toxicity level that we are trying to achieve effectively or identify to recommend the MTD, the dose of interest. And in this case, as you can see, dose level 5 is closest to the targets at the end of the study. Now, we do not obviously know the shape as well as the location of the shape of the curve as well as the location of the points at the start of the study. So we assume a model. So I'm now going to explain how the CRM works. So we specify the targets. So we specify where the red line is. We assume a model for the dose toxicity relationship. I'll explain that in the next slides. This model is often very simple, a power model or a one-parameter logistic transformation. We obtain prior guesses for the probability of DLT at each dose. Say, first dose level has a probability of 0.1, second dose 0.2, etc. Then we treat the first group of patients at the first dose level, and based on the observed data, we update the prior on the parameter of the model, and we dose the next cohort of patients at the dose level that is closest to the DLT, to the target toxicity level at that point in time. This is just one of the approaches that can be used to identify where we go effectively in terms of those levels. There can be other restrictions. For example, we can say that we are not going to skip any levels. Depends on the profile of the drug. So the Bayesian version of the CRM, more precisely, is defined in this manner. So we've got k dose levels in the study, D1 to dk. We've got our a priori guesses of DLT probability, which is what we call the skeleton. These are theta 1 to theta k. Yi is the binary outcome of interest, whether or not the person experiences a DLT at that dose level. D star is the standardized dose received by the patient. And then the power model, which is a very simple one parameter model, is specified in this manner. The probability that the response is equal to 1 is a function of the dose as well as alpha, the model parameter. And it is simply the standardized dose to the power of alpha. So if di, in this case, which is the model parameter, has a prior that is an exponential with parameter 1, the mean of alpha is 1, and therefore theta is the standardized dose. So effectively, 0.1, 0.2, 0.3, etc., which may be our skeleton, are the standardized doses. And then we are just interested in whether alpha is equal to 1 or less than 1 or greater than 1. Effectively, we just try to update the prior on alpha based on the observed data, and this will shift up and down the curve that you've seen in the previous slide. So that was it in terms of introduction to dose finding studies. Now, what is the problem at hand with new oncology agents? And I'm not talking about targeted therapies, which includes small molecules, as we say, as well as immunotherapy. What happens is that this fundamental assumption that the dose efficacy curve is monotonic may not be true. The assumption that the dose toxicity curve is increasing remains valid. It is a reasonable assumption, and this is noticed in practice in oncology trials. However, when it comes to the dose efficacy curve, it may not be true that it is monotonic increasing. And this has been seen with monoclonal antibodies. I'll discuss that in the next few slides. This has been seen with angiogenesis inhibitors, which are actually like molecules that stop the growth of blood vessels. And these blood vessels bring effectively the fuel for the tumors to grow. And with angiogenesis inhibitors, this process is affected in order to reduce the production of new blood vessels. So,
can I ask?
Yeah, sure.
Is there a simple, maybe a simple case, some good scientific understanding of why?
Yes, yes. It's perhaps a little bit beyond the scope of this statistical seminar, but it is understood why it may not actually be increasing. You may have like a plateau effect. And I'm going to talk about the possible plateau today.
Right. You expect more of a plateau.
That's right. You don't expect a U-curve. You actually do expect a plateau. However, in terms of toxicity, it may keep increasing. Now, pembrolizumab, which is a monoclonal antibody, has been around now for a couple of years. It's part of immunotherapy in terms of treatment strategies. And this table includes a recent review of 5 studies, 2 in lung cancer and then 3 in melanoma, where you can see that regardless of the dose level, the response rate doesn't seem to be particularly affected. If we look at the first one, we've got 2 milligrams per kilo once every 3 weeks in the first column. Second column, 10 milligrams every 3 weeks. And last column is 10 milligrams, but every 2 weeks. So horizontally, we've got an increasing dose level. If you look at the response rates, it is 33%, then 19%, then 19%. So there is no clear evidence here based on response rates that the dose efficacy curve is increasing. What do we mean in this context by response rates? Is the proportion of patients whose tumor is destroyed or sufficiently reduced for a sufficiently long period of time by the drug. And this is true for these 5 studies that are in the table. For example, the last one in melanoma, 2 dose levels are compared, 10 milligrams every 3 weeks or 10 milligrams every 2 weeks, and the response rate is approximately 1/3 for both. So no evidence of those efficacy curves. Here is the same with nivolumab. Nivolumab is another monoclonal antibody, has been given in melanoma, so skin cancer, lung cancer, also in RCC, which is renal cell cancer. And as you can see also in the table, there is no evidence whatsoever of an increasing dose efficacy curve. Now I'm going to tell you about this drug that was recently approved by the FDA May last year, called sotorasib. It was approved for non-small cell lung cancer defined by a specific mutation, the KRAS G12C. And it was approved by the FDA, but conditioned, interestingly, on Amgen, which is the company that developed this drug, conducting a post-marketing trial comparing 960 milligrams, which is the dose that was approved, with 240 milligrams, which is much less. Several reasons were given by the FDA. The most important one, for context today, is that there was no evidence in the accrued data. And I'm talking about the whole development program here. I'm not just talking about their phase 1 study. They also have phase 2 and phase 3 trials, larger trials, that offer a dose efficacy relationship. No evidence of such dose efficacy relationship in the data for sotorasib. So, as you can see, this is becoming an issue in the field. Effectively, less may be more with molecularly targeted agents. We know that higher dose levels tend to be associated with higher toxicities, possibly delayed toxicities. And this may lead to reduced compliance with the treatment. This also leads to treatment rupture, which may be temporary, but which may also be definitive. Overall, the previous paradigm of chemotherapy, cytotoxic agents, where identifying the NTD was the goal, is not really applicable anymore. We face these 2 possible extremes. It's either that there is a plateau on the dose efficacy curve, or that the dose efficacy curve is monotonic increasing. And at the start of the study, well, we don't know. We don't know whether there will be a plateau or not. All we can reasonably assume is that the red curve, the dose toxicity curve, will be increasing. In some circumstances, now that there is data on certain agents, including, as I said, nivolumab, for example, we know that the chances of being on the left-hand side are higher. Now, how can we approach this problem? This is where actually backfill patients come into play. So, backfill patients. This is the third part of the talk. We've got this underlying truth that is unknown at the start of the study. We've got a plateau, efficacy-wise. Let's imagine the target toxicity level is at 33%. In this case, the MTD, so the dose that would be recommended, if we were only considering toxicity, would be dose level 5. However, the ideal recommendation, if we take into account both dimensions, toxicity and efficacy, would be dose level 3 or dose level 4. Why? Because the toxicity rate would be lower for similar efficacy. That would be more cost-effective, obviously. How can we assess a possible plateau? There are 2 main options that we can think of at the moment in the field. We can run a dose escalation study in the usual way, and then randomize in a second step between the two best dose levels, the two dose levels that have most chance to be efficacious, but at the same time tolerable toxicity-wise. The main disadvantage of this strategy is that we're going to assess the possibility of a plateau just on these two levels on which we randomize. So that's the limitation of this approach. Another approach is to use backfill patients. So how does this work? We've got cohorts of patients, and they are allocated to the dose levels sequentially, as I've described in the first part of the talk. However, as soon as we are above dose level 1, so from dose level 2 onwards, we will also have backfill patients, which are dosed at those levels below where the experiment is at. So let's say we are now at dose level 3. We've got 2 levels in the backfill sets, which are dose level 1 and dose level 2. And what we can do is allocate backfill patients in addition to our dose finding patients. Obviously, the objective here is to collect information on the lower end of the dose range to assess the possibility of the plateau. The color scheme here is the following. In red would be patients who do not have a response, so the tumor keeps growing, and who do not have toxicity. In red, you've got patients with DLTs, and the DLTs, as you can see, start appearing from dose level 3 onwards in this specific example, and there are a few patients in blue who have not experienced DLTs and who have a response. So this is the sort of data set we deal with in dose finding trials. So who are these patients? They are, as I said, those at levels below the level where the dose escalation trial is at. And they are recruited mostly to annotate the dose efficacy curve further. So there will be biopsies on these patients, extra PK, PD data, so pharmacokinetic, pharmacodynamic data collected. Response rate would be measured according to RECIST criteria, which is a scheme in the field of oncology to assess whether the tumor has grown or has shrunk, etc. We can select the profile of backfill patients. They could be all comers, so same inclusion-exclusion criteria as the rest of the trial, or we can specifically target tumors of interest or biomarkers of interest, because there might be some information that subsequent trials would only be in patients with a specific biomarker anyway. But the first study is done in all comers in order to recruit more rapidly. An important point, the backfill patients, they need to be treated ethically. They should not be dosed at a lower dose level as soon as there is enough evidence that this level is not efficacious enough. So in simple terms, it is not okay to backfill a patient to dose level 1 if you know that dose level 1 is not sufficiently efficacious. At some point, dose level 1 needs to leave the backfill set. So how we do that? Well, what we suggest in the paper is to use a simple Bayesian strategy based on the beta binomial model, where we're going to just look at the posterior distribution of the probability of success, probability of a response. So imagine we call the probability of response at dose level 1, lambda 1, and the probability of response at levels greater than 1, lambda 2. With the beta binomial model, we can easily derive the posterior or calculate the probability that lambda 1 or lambda 2 minus lambda 1 is greater than 0. And we suggest to use a cutoff of 0.8. As soon as there is 80% chance, based on the accumulated data in the trial, that the response rate at levels greater than 1 is greater than the response rate at the first dose level, then we discard dose level 1 for the backfill. So in practice, this is how it would look like. After 6 patients dosed at dose level 1, our prior, which is in blue, would have evolved. In this specific example, the patient in green is a patient with a success, and the resulting posterior after 6 patients, and we've got 1 success, 5 low responders, looks like the one at the bottom of this graph. And then the study would have evolved. We would now be at dose level 4. We would have seen patients at dose level 2, 3, and 4. And we would have had, for example, 6 successes, 6 responders, and 9 non-responders. So we've got also the posterior distribution for the probability of response at levels greater than 1. And we just take the difference of these two posterior distribution as part of the NCNC sampling, for example, and we obtain the probability, the one that I was mentioning before, that this difference is greater than 80. As soon as it is greater than 80, dose level 1 is discarded from the backfill set. And then we do this iteratively. We repeat that for dose level 2 versus 3 and greater than 3 onwards during the course of the study. And really the point is that these backfill patients, they need to be treated ethically. As soon as we've got enough evidence that a dose level is not efficacious, we should not dose patients at that level just to collect extra information to better define the dose efficacy curve. It's this trade-off that we are trying to achieve. So let's go back to the starting example. We've got these two curves. We've got the dose toxicity curve in orange here, and we've got the blue curve for the dose efficacy, assuming that there is a plateau from dose level 3. So toxicity-wise, level 5 would be recommended, according to this target of 25% of DLT rates. Now, in terms of both variations, efficacy and toxicity, we want to recommend dose level 3 or dose level 4. If we use the CRM, the Continual Reassessment Method, and if we add backfill patients according to the strategy I just described, then the trial's data would look like this. This is just one example of hypothetical trial based on the curves that I've just shown. And I'm going to just take you through this graph progressively. So at the top, we've got our first 3 patients, and they were dosed at dose level 1, and they were dose-finding patients. Then the second cohort is composed of both dose-finding patients as well as backfill patients. And they are at level 2 and level 1 respectively. And we proceed in this manner. And at the end of the study, turns out that dose level 5 is the MTD, so the maximum tolerated dose, efficacy, toxicity. Why is that? Because the probability of DLT, the posterior probability of DLT using the CRM approach is 22.5 versus 32 for dose level 6. And our target, if you remember, was at 25. So we select the dose whose risk of DLT is closest to the target. Now, using the rule of 80% for the probability of a difference in response between 1 and levels greater than 1, we discarded dose level 1 after the 39th patient. Why is that? In this specific example, there were no response in 9 patients treated at dose level 1. But there were 5 responders amongst patients, the 30 patients who were treated at dose level 2 or greater than 2. So at that point in time, at patient 39, it was time to discard dose level 1 from the backfill set. I've only been talking about toxicity here. And I've talked a little bit about efficacy with respect to dose level 1 being discarded. But now, the main challenge is to identify the plateau, whether it exists or not. The observed response data is a proper roller coaster, and this is very typical of early phase trials because we've got a very small number of patients. In this graph, in the end, this is a study with 57 patients. It's only 57 patients. We've got 10 cohorts. We've got 3 patients per cohort, and for 9 of the 10 cohorts, we've got an extra 3 backfill patients. So the total is 30 plus 27, 57 patients. Very small trial. The observed response rates is plotted here in black. So if you look at the slide, you see that it's 0 for some reason at dose level 1. No one had a toxicity at dose level 1. Then it goes up, it goes back to 0 dose level 3. It shoots to 40% at dose level 4, goes back down, and goes back up around 35% from dose level 7. And this red curve is the observed data coming from the blue curve, which was our data generating mechanism, right? So when you look at the black curve, how can you tell that there is a plateau? It's really hard. It could potentially be a monotonic curve. So what strategy have we proposed in this case? Well, we fit two models, and then we decide which one represents the data best via leave-one-out cross-validation. We fit a change point model, and the location of the change point is unknown, but it has a uniform prior on the range, or a regular logistic model assuming monotonicity, right? In this specific case, it turns out that the change point model was a better representation of the data than a monotonic model. And the red curve here is the resulting fit, where the plateau will start at dose level 4. It is not a perfect representation of reality because the true plateau starts at level 3. However, it has detected that there is a plateau in this specific example.
So,
yes?
when is the blue dotted line the truth?
Yeah, the blue is the truth.
And you've simulated it with some noise in the black, in the zigzag. Right.
Yeah, well, yes, it's not noise, it's just binomial data.
Ah, okay.
It's just binomial data coming from this true data generating curves.
Okay, so, so this is P, the blue line is the probability.
Yes,
okay.
Probability of success at the various dose levels.
So this is just observation noise.
And these are the observations and the fact that the data set is so small, it looks like a zigzag.
Yeah. So is there a logistic curve on there as well?
So this is the change point model that fits the data better than a logistic curve through the backwards.
Right.
So for those who are not familiar with change point models, here is how I specify it. We've got a change point, and the mean of the observations as a function of the covariates and the coefficients vary depending on the position of your x of your covariates, whether it is prior or after the change point. This specification has one small problem, it's that you're gonna have abrupt changes before and after the plateau. But there is another specification that allows you to have a continuous continuous curve with joint sections effectively. And to do that, we can use what is called a cumulative indicator formulation. So overall, this leads to this sort of models. On the left-hand side, you've got continuous data. The x variable is comprised between 0 and 100. We've got a uniform distribution of the location of the plateau between the minimum and the maximum of x. And it's a same model with an intercept. So we've got effectively two intercepts in this data set. And the blue posterior that you can see on the graph is the location of the plateau, which here is around 50. So you see two different intercepts in this data set. And you can extend that to multiple change points, and you can extend this specification to GLM data. So on the right-hand side, we've got an example with, well, a probability of success comprised between 0 and 1 on the y-axis and an x variable. And you see that there are two change points in this specific model. So effectively, as I said before, I'm comparing these two options. A change point model, assuming one change point, versus a regular logistic model. And via leave-one-out cross-validation, I make the distinction, and I decide whether or not the data is supportive of a plateau. Now, to check whether this strategy is working in practice, I used a simulation exercise with 6 different scenarios. So we've got the same target toxicity level at 25% in each scenario. We've got a plateau in 4 and no plateau in 2 of the 6 scenarios. we've got the location of the plateau before the MTD in 2 of the 4 scenarios that have a plateau, at the MTD in 1, and after the MTD in 1 of the scenarios. At the bottom, as you can see, there is no plateau. These are straight lines, straight blue curves, compared to the ones at the top where you've got a plateau, and the plateau's location varies depending on the scenario. The result of this exercise shows the following. In scenarios A and B, as well as E and F, where effectively there is a plateau, which are the scenarios here at the bottom, we've got a large proportion of true positives. So this technique works in the sense that it's able to identify the plateau in 56 to 72% of the cases, according to the sample size that I've been using, which is 57, which is in line with regular phase 1 studies. So this is what I call the true positive plateaus. However, in situations where there is no plateau, it turns out that it's still identifying the plateau. It's identifying the plateau in 30 to 40% approximately of the cases. Now, why is that? It's mostly due to the fact that the data set is really small. And in any given situation, it could well be that despite the fact that the truth is that there is no plateau, a model with a plateau will fit the observed data better. And this happens in 30 to 40% of the cases. The good news, though, is that it happens more frequently the more shallow the curve is. If the curve is steep, then the chances of identifying a plateau is less, is reduced. And that's very good for us in the sense that if the curve is steep, and even if a plateau is identified, you're not going to lose a lot in terms of efficacy if you recommend the lower dose level. So overall, this strategy of using a regular dose finding approach to go through the dose levels and adding backfill patients allows us to identify the plateau when there is a plateau, which is important in the field. We also have proposed a strategy that treats the backfill patients ethically, so we can discard dose level 1 and then dose level 2, etc., when there is no evidence that it is efficacious. And yeah, in terms of final remarks, I was going to make the point that this backfill strategy is something that has developed over the last 2 to 5 years, and we started noticing that in clinical protocols, especially coming from the US, but this was done without any statistical framework. So protocols were written in a way that backfill patients would be added in the study in an ad hoc manner, and the numbers were not specified, and the analysis of the backfill patients was not specified either. We knew obviously what they were trying to achieve. They were trying to achieve this identification of the plateau, having seen data from nivolumab, having seen data from all the small molecules, but there was no structure whatsoever. So with this paper, what we've tried to do is provide a framework on backfill in the context of those finding trials. We propose to randomize the backfill patients to the levels below where the experimentation is at. But there are many other ways of doing it. But without that, randomizing them was perhaps the most ethical way to do so. Backfilling increases the study time, but it's a price that is worth paying to properly annotate the dose efficacy curve. And that is it. That is it for my talk. So thank you very much for your attention.